Hi everybody, I'm Katherine Morrison, and I'm going to be presenting the clinical piece, talking a little bit about the problem of childhood obesity, which is one that I look after in the clinic, and also some of the clinical research that speaks to the question that is raised here, which is, does childhood obesity begin in the womb? I don't have a conflict of interest related to this talk, and really what I wanted to do was to cover for you some of the important aspects related to the challenge of childhood obesity in terms of the magnitude of the problem. Not just thinking about the number of kids that have problems with obesity, but the health consequences that are related to that. So I'm going to start there, and then I'm going to enter into some literature that's come out over the last now almost 2 decades, where we've started to delve into the earliest life experiences and how they influence a child's health across their life cycle. And then we're going to proceed into Alison's conversation and discussion with you about how we can answer that question, not in patients or in study participants that are human, but rather in the animal and basic science laboratory. So it will not be a surprise to anybody in this room that childhood obesity is a problem in Canada, and frankly, I used to say in developed countries, and now I can unfortunately say in countries around the world, both developed and developing. In Canada, we've had childhood obesity rates increase quite dramatically over the last 25 years. And the graphic that's there is a graphic of between the 2 times over 25 years when we actually measured childhood heights and weights in this country, rather than taking people's word for what their height and weight are. And you'll see that over that time, the obesity rate almost tripled. The number at the bottom, which is now another 5 years later, it was published in 2011, and it uses slightly different normative data, so there are some changes in the data, but basically it tells us that almost 1 in 3 of Canadian children are either overweight or obese, and that is more than 1 million kids in this province. There has been a lot of discussion as to why. Why have we seen this blossoming problem over the last 3 decades? And I'm not going to be able to go through all of the detail that has been sort of coming out of the literature and really coming out of our looking at obesity as more than a problem of individuals. And we started off saying this is a family problem, this is a child problem, somebody's messing up badly with what they're doing to their children. And we have fortunately awoken to the fact that in fact all of us are equally responsible, because the society has been changed quite dramatically and we each have a role in that, meaning that we each are going to have to play a role in reversing it. And that's not what I'm going to talk about today. That's my little, when I get on my soapbox, but really today we're going to focus very much on the child and the family. But I wanted you to consider the fact that the work that people do, the education that they have, the environments in which they live, very much impacts decisions that children and families take. So what do I know about health and childhood obesity? Who cares about this really anyway? Well, there's been some really excellent longitudinal studies that have come out over the last 2 to 3 years, and this is an example from one of them. And really very simply, and you can see I've grossly simplified the graphic, but that you can predict if a child, an adolescent, is obese, that they have about a 7-fold increased extent of atherosclerosis, and this is measured by looking actually at the coronary arteries using imaging by the time they turn 40, compared to the population of individuals who were not obese as adolescents. The risk of diabetes is about 5-fold higher, and the good news is that if they don't have obesity anymore as adults, their risk of diabetes is exactly the same as somebody who was lean as an adolescent. So there is an advantage to actually pursuing treatment and trying to normalize body size. So how many of you have heard of metabolic syndrome? Most of you. So metabolic syndrome is really just a clustering or a gathering together of a number of conditions that individuals have, and we see them often grouping together, associated with people who put fat on their bellies. So if you put fat on your backside, you don't see the same relationship with these problems. But if you are a person who has an apple shape or puts fat on your waistline, you have a higher risk of having impaired glucose tolerance, which we call prediabetes, or type 2 diabetes. You have low good cholesterol levels, you have a higher risk of having higher triglyceride levels, and you can have higher blood pressure. And all of these are known as cardiovascular or cardiometabolic risk factors because they increase your risk of having cardiovascular disease, particularly atherosclerotic cardiovascular disease. Well, what about kids? Do we see that in kids? We do, unfortunately. And the bad news is if we now take that adolescent and they have metabolic syndrome, now they have a 14-fold increased risk of having a heart attack before they turn 50. And I don't know how many of you are involved in clinical medicine, but you'll be very well aware of the fact that people, that's not the normal age to be having heart attacks. We don't think about heart attacks in your 40s as the sort of usual age group that will see those patients. So this was really very disturbing when it was first published. So how do our kids look? Well, this is just an observational study of a group of 260 kids that come to our clinic. They were not screened in any other way other than that someone thought that they should be part of a clinical weight management program. And we didn't pay any attention to all of the suggestions in terms of guidelines about who we should screen for what. We just screened everybody. So everybody from the age of 5 to the age of 17. And what we found, unfortunately, is that 1 in 5 of the kids coming to our clinic already have prediabetes. And there's one longitudinal study only in kids, and it shows us that about 12% of those every year would be expected to progress to type 2 diabetes. 80% of them have at least one of those cardiovascular risk factors that I mentioned. And about 20 to 25% of them have multiple risk factors, so they fit that metabolic syndrome picture. So if you think about that risk that I told you about, an adolescent who has a 14-fold increased risk of heart disease, you'll see what motivates me to try and understand how to impact the kids that are coming to me and how to prevent more of them from entering into our clinic. But that's not why they come. People that are referred to our clinic don't come, usually, because somebody read somewhere that their blood pressure might be up or they might have a heart attack 40 years from now. And I can tell you that for the kids, having a heart attack when they're 50 seems like, you know, centuries away. So that's not the reason they're there. A very large percentage of them come because of concerns about psychosocial health and mental health. And you can see we did a screen for depression, and about 1/3 of the kids have very high depressive symptoms that would put them over the threshold for needing to have further evaluation. They in general report a very low quality of life, and they report lower self-esteem and lower confidence in themselves to do things that might make sense to you, like physical activity, but also to do other things. So lower sense of their capabilities. Is it everybody that comes? No, of course it isn't. But those problems are more prevalent in this population. So what are the causes? What are we learning about all this cardiometabolic health? And this is, I've put this paper up because it's kind of a classic paper now. It was first published in 1989, and any of you who are interested in the early origins of cardiometabolic or cardiovascular health will know of it. This is Barker's paper, where he looked at individuals and he just looked at the chances that they would have a heart attack. These were men only in a community in England. And then he looked at their birth weight. And much to everyone's surprise, he published that the lower your birth weight, the higher your chances of having myocardial infarction. So why should I care about that in the kids that come to my clinic? Well, the atherosclerotic process is one that actually begins well before they come to my clinic. The atherosclerotic process actually begins when they're in the obstetrician's clinic, because it begins in the womb We know that the earliest signs of atherosclerosis, called a fatty streak, are present in newborns. And we also know from studies in young people, particularly in the second decade of life, that the extent of atherosclerosis that you have in your vessels depends upon those risk factors that you had earlier in life. And this was done in a study of young people who had been followed and who unfortunately had died in an accident, and the families had agreed for the vessels to be looked at. So this is actually looking at pathological specimens. Well, I mentioned the life course approach, and this is a graphic that I'm going to show you a couple of times today, and it's a little bit busy, so I'm going to walk you through it. So as a pediatrician, about 90% of the important parts of your life happen before you turn 18, and that's what's represented in my graphic here. But really what I'm trying to emphasize to you is that there are stages of life, and we think that those stages contribute to your health down the road, and that these may be windows of opportunity in the case of exposures that might prevent you from developing something, or windows of increased risk. And the one we're going to talk most about today is related to fetal life, but there are other windows of opportunity as you go throughout early childhood, infancy, into your young childhood years, and then progressing into adolescence until you eventually become an adult. And the important aspects are that we are beginning to understand that this becomes a vicious cycle, and that that ill health that develops in a mom and perhaps even in a dad has an impact on the ill health of their offspring, and may be part of what is driving this ever increasing rate of childhood obesity. So Barker's paper said if you had a lower birth weight, you had a higher risk of having a heart attack, and everybody said, oh man, birth weight, birth weight. Well, birth weight is really just a measure, and a very crude measure, for how did your pregnancy go? How was the nutrition? How was the in utero environment? How was the communication or the transfer of nutrients from the mother to the fetus, which can be influenced by a large number of things? How was mom's health impacting the baby? And so really birth weight is a measure of disturbances for optimal health. And we have some very early human studies which are rather unfortunate in their occurrence, but the Dutch famine, during World War II, there was restriction to the food supply for a very fixed amount of time in the Netherlands. And it was called the Dutch famine. Is that something that you guys have been familiar with? Yeah. So in following up individuals whose moms were pregnant during this time, we've come to understand that these marked periods, and this is a very marked period of undernutrition for a defined period, can have quite considerable impacts on the outcome of their offspring. And not just at birth, but across the lifespan. And so what they did in fact show is that there's increased risk of both more fat around the belly, and we measure that using waist circumference, and increased BMI in those whose moms early in gestation were exposed to extremely low nutrient intake. So it looks as though being small as a newborn, perhaps because of nutrient deficiency, but there are other reasons why babies are small, can increase central adiposity and lead to metabolic disturbances as well. And some of those other reasons for being small include cigarette smoking, and you're going to hear a little bit more about that as we go. Well, this is now switching steps. People have said, okay, there's something going on in utero, and I've chosen just one study. There are a number of birth cohort studies that are ongoing. I've picked this one for a couple of reasons. Number one, it's large. They started off with about 3,000 individuals. The second main reason is because they didn't just measure body size, which is of interest, but what I really want to know is about the health of those individuals. And so they actually went and measured kids at 8 years of age, but they also measured those cardiometabolic risk factors that I spoke to you of. And they were able to look at a large number of what we call determinants to try and isolate the impact of birth weight on cardiometabolic health of the kids when they were 8 years of age. And you'll remember markers with just the low birth weight being related to increased risk of a heart attack. This study and many others, frankly, that have come since that have just looked at BMI showed that it's not just the smallest babies, although the babies in the lowest quintile, so that's above the 1 on the graphic on the left, those babies have an increased risk of clustering of these cardiometabolic risk factors, but so do the babies with the highest birth weights in the top 40%. And so it seems that being in those two middle quintiles predicts the lowest cardiometabolic risk later in life. So it's not just being small, also large babies seem to have higher risk of central adiposity and metabolic disturbances. And that becomes complicated as we think about it, but it's been a very consistent finding in multiple studies. I don't have time to go through the myriad of data that is starting to now look at overnutrition of the baby and its impact. But what we've come to understand quite consistently is that moms that are obese or moms who put on more weight than is recommended during pregnancy, so high gestational weight gain, both of those predict abnormalities in cardiometabolic health later in life. And this goes beyond just the size of the mom. It may also speak to overnutrition, though, because this is looking at what happens to the offspring of moms with diabetes. And this is older data now, but it was the first study that came out, and that's the reason that I'm presenting it as a classic paper. It was done in the Pima Indian population. Are you guys familiar with Pima Indians? Pima Indians they're First Nation people in the United States, in Arizona in particular, and they have very, very high risk of type 2 diabetes. They're one of the highest. We know that First Nation people across North America and frankly Aboriginal people in other communities also have high risk of diabetes, but the Pimas have really particularly high risks. And what they looked at was the influence of mom having diabetes during her pregnancy to diabetes in the young people as they went through life. And they had very fixed follow-up of these individuals within the community. And what you can see, if you look at the solid bars compared to the open bars, is that by the ages of sort of early adulthood to to the mid-30s, that there's a much higher risk of diabetes if mom had diabetes. One of the interesting things about this study, though, is to look at the white bars, so the group in the middle. Because although I've put pre-diabetes, I probably should have labeled that differently, because what it actually means is moms who did not have diabetes during the pregnancy but developed diabetes later in life. So may very well have the same genetic increased risk for passing that on to their kids. And they also have increased risk of diabetes in their offspring. There's been some subsequent studies in non-PIMA populations finding the exact same thing. And what's really important, if you say to me, yeah, but Dr. Morrison, it's just because they're genetically more likely to get diabetes. But interestingly, if the fathers have diabetes, there is no such increased risk in the offspring to the same extent. So it appears to be something that is delivered to the fetus, or an exposure to the fetus in the womb, that is important. Now, that's just a quick summary slide looking at some of the things that are resonating in terms of being recurrently shown as predicting increased obesity and increased problems with cardiometabolic health in kids. I'm going to just touch on a couple of really important issues that we see later in life, because it's important to understand, okay, so the baby's born, I'm a clinician, and I'm not an obstetrician, so as a pediatrician, is there anything that I can do to impact positively this negative, potentially negative outcome. And we are learning more about infancy and about health in infancy and nutrition in infancy, as well as in early childhood, that may actually influence the postnatally influence the prenatal exposures. The most common one for us to study is breastfeeding. Clearly, these are not randomized control trials. It would be completely inappropriate of us to decide we were going to give breast milk to some and not to others. And there's lots of good reasons to breastfeed, and one of them seems to be that your kids have a lower risk of developing obesity. There's been so many studies because you'll see that they're not all consistent. And we are not exactly sure whether there's a mechanism, what the mechanism is. There are some that suggest that it's actually the content of the breast milk. There are others that say, no, it's because breastfed babies are given greater opportunity to develop their own sense of satiety. They know when they're full, they stop feeding, whereas bottle-fed babies tend to be fed until the parent tires of feeding them. And so they think that maybe breastfed babies recognize those satiety signals better. And there's others that say, no, you know, it's not actually breast milk or anything around breastfeeding. It's the people that breastfeed are more likely to have other healthy lifestyle behaviors and pass those on to their families. There's been a lot of studies that have tried to correct for lifestyle behavior, and those are still showing an impact of infant feeding. So I think probably infant nutrition does have a role. I'm just not 100% sure how. And the other very, very common factor that you'll hear about is how fast babies grow early in life. So I've talked about their birth weights, but how fast they grow, particularly if they do grow very quickly early in life, in infancy as well as in early childhood, that speed of growth seems to predict increased adiposity later in life. We don't know, we don't understand that very well, but this is where we do think that the environment is very important. So the nutritional environment that they're exposed to, as well as their physical activity and sleep behaviors. This is a meta-analysis that Alison's going to touch on again, and because we're getting so many of these longitudinal studies, we've come into the days of meta-analysis. And this is just to reconfirm for you some of the things I've said, which are robustly associated, and that being high birth weight, maternal pre-pregnancy overweight, so heavy mums, and maternal smoking in pregnancy were underlined as important, the key sort of features related to childhood adiposity. But the early rapid weight gain also appeared within these 30 studies. And that suggests that now my graphic's getting a little more complex again, that both small and large size at birth followed by rapid weight gain leads to central adiposity and metabolic disturbance. What we don't really have clear yet is, must you have rapid weight gain through childhood in order to convey these impacts? And I wanted to take you back to this study. So I presented this study, and you'll see the lower left corner is the graphic that I showed you before. And now they've corrected for postnatal weight gain by tertile. So they just took the ones who grew the fastest in the middle and the least. And the ones who grew the fastest from birth were in the white bars. And if you compare the white bars at the back, you'll see, yeah, there is still an impact of birth weight, but really what's impacting the clustering of risk factors at 8 years of age appears to be how rapidly they grew from birth to 8 years. And we need to try and understand the interplay between those two. And to close, I'm going to talk about a couple of things that are ongoing here. I mentioned that I do clinically based research, or some epidemiological research as well. And I wanted to touch on two studies that very directly are evaluating early exposures and subsequent obesity and cardiometabolic health in kids. And the first study I want to talk about is the family study. Kun Teo here in cardiology is the principal investigator of this study. And I notice Nora's here. She's the lady who actually does all the work. Nora has been very actively following these young people up now. They're no longer babies. This is a cohort of 900 babies or so who were born in Hamilton and Burlington. And our primary outcome is to examine the body composition of these kids at 3 and at 5 years of age. We're very nearly finished the 3-year age group, so we're excited to begin to analyze that data or to complete the analysis of it. And the oldest of these babies are no longer babies, as I said. They're now just beginning their 2nd decade of life. So we've been funded by CIHR to continue to follow them into their 2nd decade. We were interested in measuring body composition with DEXA, so we very accurately can measure body fat. And we're also interested in measuring their cardiometabolic health. And we've looked at determinants that are quite broad in their coverage and include pregnancy-related determinants and as well as parental health, both mom and dad. And then we're measuring aspects of the family environment as well as they proceed through life. And I wanted to just show you a pretty complicated graphic from a paper that was just published. And this is a paper that really only covers cardiometabolic health up to 1 year of age. So we're still, these are not even 1 year, these are really the newborn findings. So this is based on cord blood and body size at birth. And we clustered together the newborn cardiometabolic traits, and they clustered with the lipids together, which is the light blue, the glucose status in yellow, blood pressure in purple, and at the very top was the body size or the fatness measured by skin folds, which clustered together with insulin levels. And that makes sense for those of you who know that insulin is actually the most important growth factor during fetal life. At any rate, we then said, okay, so what are the things that might predict these risk factors? And on the left side are the positive things. So you'll have increased levels of HDL cholesterol or glucose or body size with those characteristics being higher. So higher maternal weight and higher maternal weight gain during pregnancy both independently predicted the baby's body size, as we saw from previous studies. Interestingly, mom's blood pressure and mom's lipid levels also appeared to have an impact on, or to be related to at any rate, the baby's lipid profile at birth. On the negative side, in terms of an inverse relationship, as opposed to saying this is a negative, bad relationship, it's an inverse relationship, maternal smoking, which is what we'd expect because maternal smoking predicts lower body birth weight. One of the unique findings of this study is that the intake of polyunsaturated fatty acids related to saturated fats. So saturated fats are your animal fats. PUFAs are the ones that you should have quite a lot of, that those who had lower amounts of PUFA intake for their saturated fat intake had bigger babies. Mom's age and her good cholesterol levels also impacted lipids. And finally, the size of the baby relative to the placenta had an impact on, or was related to the baby's glycemic status. Nothing predicted blood pressure. And that's been found in other studies in older kids, that very little predicts, blood pressure seems to be out there independently in terms of risk factors. One of the other studies, and I'm going to close with this, is a study that I'm now involved with, but this is really a study that owes its origins and its longevity to Sarosh Sehgal, who's a neonatologist here at Mac. And she, around the late 1970s, early 80s, was when premature babies who were under 1 kilo were beginning to actually survive. And Sarosh had the foresight to think about understanding what the health of these babies would look like after they left the nursery. And 179 survived, 13 unfortunately died by the time of this follow-up at 23 years of age. And then she was able to actually follow 90% of them up to 23 years. She picked up a normal cohort that was matched, born in the same hospital, same day, and same socioeconomic status as the babies that she'd been following at 8 years of age. And amazingly enough to me, this group also is very, very rigorous with coming back for their visits. So definitely a credit to her and her team. But what you can see about the growth, and this is a busy graphic, if you look at the very top, are males and the bottom is females. On the left is the weight, and you'll see that they were very underweight and they were also very small in height around their early years of life. But gradually, over the course of their lives, their weight has come much closer to the normal birth weight group. Their height has stayed low, and they actually, both males and females, are shorter than the normal birth weight cohort. And their BMI is the same. So if they're shorter with the same BMI, we ask the question, do they have more body fat and do they have more ill health? Because that's exactly the pattern of growth I told you was related to problems with cardiometabolic health later in life. So we are following them up. They're now in their early 30s, and we're almost finished. We were funded by CIHR to do this, and we're working together with a Finnish group who has done this with a cohort in Helsinki. And they've shown that, in fact, there is some increased blood pressure, and there is some evidence of abnormalities in blood sugar in these young people. But they were unable to measure body composition. So we have chosen to look at body composition and other markers, the sort of traditional markers. And then we're also looking at atherosclerotic load using an ultrasound. So it's a non-invasive marker. We look at the carotid arteries, and we're looking at the thickness of the intima media to see whether or not these now young adults actually have increased atherosclerosis relating back to their perinatal adversity. I don't have answers for you on that one yet, but stay tuned. We should be presenting, I hope, soon. So we like to think that we're at the cutting edge of research, and that we're really, this understanding of the early origins of health is something that's kind of newfangled. So it's sobering to read from Leonardo da Vinci's notebook, quite a few hundred years ago now, that this work must begin with the conception of man and describe the nature of the womb and how the fetus lives in it, and in what way it quickens into life and feeds. Also its growth and what interval there is between one stage of growth and another. So I hope that I have convinced you that atherosclerosis begins early in life, that children and youth do develop all of the cardiometabolic problems that adults are known to develop, and that we really need to understand the early risk factors for these. Genetic background is important, but it's only part of the story. The health of the mom, the environmental exposures in fetal life and in early childhood, and growth trajectories all play a really important part. But what I can't answer in clinical research very well, or as well, is why and how does the environment in utero impact health, because I can't actually go in and intentionally change the in utero environment. And that's something that we in the clinical world rely on our basic science and animal research colleagues to answer for us. And I've had the pleasure of working with Alison for quite some time to look at that. And she is, in a few minutes, going to come up and talk to you about some of her work in that regard. Before I do that, we're going to take questions at the end. But are there burning questions that anybody wants to ask at this point in time? You're worried you're going to forget them later? Nope? Good. Okay. So we'll address questions together at the end then. Alison?